When you find yourself having to make a really critical medical decision, whether that's for yourself or your partner or, maybe your child.
Right. High stakes.
Exactly.
Yeah.
There is this certain kind of structural certainty that you are just desperately hoping for.
You want it to be black and white.
Yes,
Yeah.
you want the process to feel like, I don't know, like engineering. Like if you are building a bridge, you look at the stress tests, you pour the concrete, and you just know it's going to hold the weight.
Yeah, or like setting a broken bone.
Right, exactly. You go to the hospital, the X-ray shows that jagged white line on the screen, and the doctor just points at it. And there it is. Broken or not broken. It's this clean, visible, undeniable reality. And here is the exact fiberglass cast we're going to use to fix it.
And that kind of binary categorization, I mean, it is deeply comforting to the human brain. We naturally gravitate toward those neat little boxes.
Oh, totally.
We want a clear map where X marks the spot, right?
Yeah.
And we want a treatment plan that feels, well, as definitive as setting that bone.
But then you step into the world of neurodevelopment.
Yeah, that's where the map disappears.
It really does. Specifically, you step into the world of trying to figure out how to treat attention deficit hyperactivity disorder, or ADHD, and suddenly that comforting X-ray machine it's completely shattered.
It's gone. The compass is just spinning wildly.
Right. Imagine standing in that position, having to make a choice that will alter your child's brain chemistry, or trying to salvage your own struggling career.
It's incredibly daunting.
And every single article you read online completely contradicts the last one you read. Like one blog says a certain medication is a miracle cure, and then the next one says it's a dangerous toxin.
Which is the absolute definition of diagnostic and therapeutic muddy waters.
You are just standing in the middle of this dense, foggy information landscape, and you have literally no idea which way is north.
And for a person trying to navigate it without a medical degree, it feels incredibly isolating.
Oh, I can only imagine.
And the scale of this confusion is massive because the condition itself is so prevalent,
Yeah.
and so impactful.
Yeah, the stakes for navigating this correctly are just astronomical. I think people who don't have personal experience with ADHD sometimes dismiss it.
Oh, constantly. They think it's just an excuse.
Right. They think it's just having a little trouble focusing on a spreadsheet, or a kid who gets a little too bouncy in math class. But we are talking about a condition that carries a staggering societal and personal burden.
The numbers are actually hard to wrap your head around.
They really are. I mean, the estimates in the United States alone put the excess societal costs at like $122.8 billion just for adults.
Wow, yeah.
And for children, it's another $19.4 billion plus $13.8 billion for adolescents.
And that's just the financial footprint, right?
Exactly. That encompasses healthcare costs, lost productivity at work, special education resources. But beyond the money, it ripples through every single aspect of human existence.
It affects everything.
We are talking about academic achievement, the stability of marriages, the risk of physical injuries, traffic accidents. The entire trajectory of a person's quality of life is on the line here.
And, that burden doesn't magically vanish when a person blows out the candles on their 18th birthday either.
Which is such a common misconception.
It is a stubbornly persistent myth. Up to 70% of children with ADHD continue to experience impairing symptoms right into adulthood.
70%. Wow.
Yeah. It is very much a lifelong trajectory. Yet, the current landscape of information available to people living with this, or even to the clinicians trying to treat them, has historically been a total mess.
Just a tangle of conflicting studies.
Exactly. Very narrow viewpoints and crucial data that is locked behind expensive academic paywalls where, the average person can't even read it.
Okay, let's unpack this. Because you, the listener, do not have to stay lost in that foggy landscape anymore. Today, we have a way through.
A very clear way through.
A really, really powerful compass. We are doing a deep dive into a massive, monumental 2025 study that was published in the BMJ, the British Medical Journal.
And it really is monumental.
It is. I use that word intentionally
Yeah.
because this isn't just a standard laboratory experiment, right?
Not at all.
It is an umbrella review aimed squarely at cutting through decades of noise and decades of confusing medical jargon.
Right. To figure out what the highest quality gold standard evidence actually says about the benefits and harms of these treatments across an entire lifespan.
So defining what an umbrella review actually entails is pretty crucial here.
It is, because it is not a term that gets thrown around casually, even in scientific circles.
No.
It represents the absolute pinnacle of the evidence hierarchy in modern medicine.
Okay, break that down for me. What's the hierarchy?
Let's layer it. So in a standard clinical trial, a researcher looks directly at a group of patients, right?
Makes sense.
Moving one level up, in a meta-analysis, a researcher gathers up a bunch of those individual clinical trials, pools all their data together, and looks for a consensus.
Okay, so that's a meta-analysis.
Right. But this umbrella review, the researchers didn't just look at trials. They looked at 221 unique meta-analyses.
Wait, so it is quite literally a meta-analysis of meta-analyses.
That is the perfect way to describe it. Those 221 meta-analyses were derived from 47 distinct, massive meta-analytic reports.
That is a staggering amount of reading.
It's an ocean of data. To get there, the research team started with over 4,600 records pulled from 6 different major scientific databases.
Oh my God.
Yeah. They synthesized data covering 31 different specific interventions and 24 different clinical outcomes. And what's fascinating here is that the ultimate goal of the researchers wasn't just to publish a static paper.
Right, they didn't just want to collect their accolades and let the journal sit on a shelf collecting dust.
Exactly. The mission was to build the foundation for a continuously updated, open-access living database.
A living database. I love that concept.
It's brilliant. It is a tool designed specifically to empower people with lived experience and their doctors to practice actual shared decision-making.
Using data that has been, rigorously scrubbed and verified, let me try a metaphor here, see if this tracks.
Go for it.
If a single clinical trial is like a single pixel on your computer screen and a regular meta-analysis is a photograph,
Right.
then this umbrella review is basically a high-definition, continuously updating satellite map of the entire ADHD landscape. It lets you see the whole continent, but you can still zoom in on a specific city.
That captures the scale perfectly. It provides the macro view of the entire field without losing those essential micro details of individual treatments.
So I really want to get into how they actually built this satellite map, because separating the good data from the bad data in medical research sounds like an absolute nightmare.
It's incredibly complex.
Why was this massive undertaking even necessary in the first place? If there were already 221 meta-analyses out there, wasn't the science already pretty well settled?
You would think so, yeah. But the researchers noted that the existing pile of meta-analyses was frequently failing both patients and clinicians on multiple fronts.
Failing them how?
First of all, the scope of previous reviews was often way too narrow. A paper might focus exclusively on one specific intervention. Let's say just methylphenidate. Or maybe just one specific outcome, like academic performance. That is great for answering a very tiny, specific question, but
it doesn't help a clinician who has a patient sitting right in front of them in their office.
Exactly.
Right.
Because that clinician needs to weigh 5 entirely different treatment options against each other.
Right. It's like if you have a massive toolbox, but the instruction manual only tells you how to use a wrench, you're going to be pretty useless when you need a screwdriver.
That's a great way to put it. Secondly, and frankly far more concerning for the medical community, these existing meta-analyses were frequently showing entirely conflicting results about the exact same intervention.
Wait, really? The exact same drug would get different results?
Yes. The BMJ paper specifically calls out neurofeedback and cognitive training as prime examples where the historical data was just a chaotic tangle of contradictions.
Oh, wow.
You could read one meta-analysis that concluded neurofeedback works wonders, and then read another published a year later that concluded it is literally no better than a placebo.
Which is exactly why someone sitting at home, scrolling on their phone at 2 a.m. Googling ADHD treatments feels like they're losing their mind.
Precisely.
Because the experts don't even agree with each other.
And that leads to the third major failure. Many of these previous meta-analyses completely failed to rate the actual quality of the evidence they were compiling.
What do you mean by quality?
Well, they would eagerly report an effect size. They'd say, hey, this drug improved symptoms by 30%. But they wouldn't tell you if the underlying studies they used to get that number were rigorously designed, or if they were fundamentally flawed, tiny trials with massive biases. And this drastically slows down the implementation of evidence-based medicine.
Right, because global health organizations can't confidently write treatment guidelines if the certainty of the underlying evidence is just a mystery.
Exactly. So the researchers for this BMJ paper couldn't just aggregate the old data and call it a day. They had to act as the ultimate filter.
So I was reading through the methodology, and I know they use something called the URECH framework. Walk me through that because it sounds intense.
The URECH framework is intense. It stands for Umbrella Review, Evaluation, Analysis, and Communication Hub.
Catchy.
Very. It is a highly systematized protocol for managing this exact kind of data deluge. As we noted, they started by casting a really wide net, capturing 4,632 records.
From places like PubMed and the Cochrane Library, right?
Yep, and Embase. From there, the screening process was incredibly ruthless. They manually excluded hundreds of full-text articles.
On what grounds? Like, what gets an article thrown out?
Well, for example, if a study had an unclear definition of what constituted an ADHD diagnosis, it was thrown out immediately.
Okay, that makes sense. You need to know what you're treating.
Right. If it used the wrong study design, or if its methodology wasn't transparent enough to be replicated by another scientist, discard.
So they just slash through the pile.
They whittled those thousands of records down to just 115 eligible, robust reports.
Wow. And from those surviving 115 reports, they extracted those 221 unique combinations of participants, interventions, comparators like placebos, and outcomes.
Correct.
Now, earlier I was thinking of them like a bouncer at a club just checking IDs at the door. But looking closer at this framework, that's not quite right. A bouncer just checks your age. These researchers were acting more like forensic accountants.
I like that.
They didn't just look at the final number a study reported. They asked for the receipts, and they audited the books.
That forensic accountant analogy is incredibly accurate, actually. To conduct this audit, they deployed two very distinct, very strict grading systems. First, to evaluate the methodological quality of the meta-analyses themselves, they used a tool called AmStar2.
Okay, stop right there. What exactly is AmStar2, and what makes it different from grading the underlying science? Is it just looking at the math?
Not exactly. AmStar2 stands for a measurement tool to assess systematic reviews. It doesn't look at the patients or the drugs.
Then what is it looking at?
It looks at the behavior of the scientists who wrote the meta-analysis.
Oh, fascinating. Grading the graders.
Exactly. It asks a series of critical questions. Did the authors register their research protocol before they started, so they couldn't just change their goals halfway through if they didn't like the results?
Right, no moving the goalposts.
Did they comprehensively search all available databases? Or did they just cherry-pick studies they liked? Did they properly account for the risk of bias in the individual trials they included?
So AmStar2 grades the structural integrity of the review itself.
Precisely. And the results of this audit were pretty revealing. Out of the 221 meta-analyses they kept, about 59% were deemed to be of high methodological quality.
Okay, 59%, not terrible.
7% were moderate, and a full 34% were rated as low or critically low quality.
Wait a second. They kept the ones that scored critically low. Why wouldn't a forensic accountant just shred those files immediately?
They kept them temporarily to ensure the map was complete, but this is where their second and arguably more powerful grading tool comes into play.
What's the second tool?
An algorithmic adaptation of the grade framework. While AmStar2 evaluates the scientists who wrote the review, GRADE evaluates the certainty of the actual evidence underneath it all.
Okay, so GRADE is looking at the actual data.
Right. It stands for Grading of Recommendations, Assessment, Development, and Evaluation. This is the gold standard system that classifies the certainty of medical evidence into 4 ordinal classes: high, moderate, low, and very low.
So how does this algorithmic version of GRADE actually punish a study that's doing something sketchy?
Well, the researchers programmed an algorithm to systematically look for specific red flags in the primary randomized controlled trials. Even if an entire meta-analysis was structurally sound according to AmStar2, if the individual clinical trials inside it were heavily biased, the algorithm caught it. For example, if the assessors who were rating the patient's ADHD symptoms knew which patients were taking the real drug and which were on the placebo.
Oh, yeah, that's a huge lack of blinding.
Exactly, the algorithm would catch that lack of blinding. Or if a trial measured 10 different outcomes but only reported the 3 that looked positive,
Classic cherry picking.
the algorithm would mercilessly downgrade the certainty of that evidence from high down to low or very low.
Okay, so they're grading the reviewers and they're algorithmically grading the underlying trials. But I want to go back to the math aspect of this forensic accounting.
Sure.
If they are recalculating the math from all these older studies, did they find outright mistakes? Like, were there just bad calculations floating around in the scientific literature influencing how doctors prescribe medicine?
They absolutely found mistakes. And this is perhaps the most crucial strength of this entire umbrella review. They refuse to blindly trust the summary statistics reported in previous papers.
They didn't just take their word for it.
No, they went all the way down to the bedrock. They extracted the raw data at the individual randomized controlled trial level and completely re-estimated it using a standardized statistical approach.
Wow, that is a lot of math.
They used a specific package called meta-umbrella within the R software environment. The goal was to force everything into an apples-to-apples comparison.
Give me an example of the kind of mathematical mistakes they had to fix. What does a broken equation look like in psychiatric research?
The most glaring issues were effect sizes that were simply biologically or psychologically implausible. To understand this, we need to quickly discuss what an effect size is.
Please do.
In these studies, they use a metric called a standardized mean difference, or SMD. It basically tells you how much of a difference an intervention actually made compared to a control group. Generally speaking, an SMD of 0.2 is considered a small effect. An SMD of 0.5 is a medium effect. An SMD of 0.8 is considered a large effect.
So in point 8 is moving the needle significantly.
Right. But the researchers found older studies claiming to show standardized mean differences of 3.0 or greater.
Wait, a 3.0? What does a 3.0 even look like in the real world?
A standardized mean difference of 3.0 means the group getting the treatment and the group getting the placebo barely even overlap on a bell curve anymore.
That sounds suspicious.
It is. To put it in physical terms, it's the kind of statistical difference you would see if you were comparing the height of an average adult male to the height of a 2-year-old toddler.
Oh, wow.
Yeah. And complex, nuanced psychiatric and neurodevelopmental interventions where human behavior is incredibly variable, an effect size of 3.0 is a massive flashing red flag.
It almost certainly means something in the underlying math or the way the trial was designed is fundamentally broken.
Ah, I see. So when the researchers saw a 3.0, they essentially said, yeah, I don't believe you. Show me the raw numbers.
Exactly. They used a specialized tool called metaconvert to trace the math backward. If they found that a meta-analysis contained clear inaccuracies or mathematical errors that couldn't be resolved by looking at the raw data, it was entirely excluded from the final map.
Good. Get it out of there.
Beyond fixing errors, they also had the monumental task of harmonizing all the different statistical languages being used.
What do you mean by statistical languages? I thought math was math.
Well, medical researchers over the decades have used different metrics to report their findings. Some older studies reported their results using odds ratios, others used risk ratios, others used mean differences.
Oh, I see. It's like trying to compile a master financial report when you have receipts in dollars, euros, yen, and pesos.
Exactly. The researchers had to convert everything into a universal currency.
How did they do that? For continuous outcomes, like a score on an ADHD symptom rating scale that can slide up and down, they converted everything into a standardized mean difference. For dichotomous outcomes, which are simple binary yes or no scenarios like, did the patient drop out of the trial, yes or no, they converted everything into a risk ratio.
Okay, I notice in the methodology they also mentioned something called a continuity correction, specifically adding a 0.5 to contingency tables.
Yes.
I want to make sure we don't leave the listener behind with the jargon here. Why would you arbitrarily add half a point to a math formula? What is breaking the math?
It's a really fascinating statistical quirk. Imagine a clinical trial testing a new drug for side effects, and it's a relatively small trial with, say, 50 people.
Okay.
The drug is so well tolerated that literally 0 people in the treatment group experience a specific side effect, like insomnia. So you have a 0 in your data column.
Sounds like a great drug.
It does. But when statisticians try to calculate a risk ratio, they have to divide the risk in one group by the risk in the other. But if you remember from grade school math, you cannot divide by 0. It breaks the equation.
Oh. So the formula basically explodes and gives you an error message?
Precisely. So to get around this, statisticians use a continuity correction. They artificially add a tiny, virtually insignificant fraction, in this case 0.5, to the cells of the data table.
Like a phantom participant.
Yes, exactly. It doesn't meaningfully change the final conclusion of the study, but it satisfies the mathematical formula so the algorithm can process the data and compare it to other studies.
That is brilliant. It's like putting a tiny shim under a wobbly table leg so you can actually use the table.
That's a great way to picture it. And the final piece of their forensic accounting was something called a corrected covered area analysis.
Okay, what does that do?
It is a mechanism to aggressively check for data overlap or double counting.
Double count.
Yeah. Let's say a massive, groundbreaking clinical trial on methylphenidate was published in 2015. Because it was such a good trial, 5 different meta-analyses published between 2016 and 2020 all included that same 2015 trial in their calculations.
Okay, I see where this is going.
Right. When you are building an umbrella review, you are looking at all 5 of those meta-analyses. If you aren't careful, you will accidentally count the result of that single 2015 clinical trial 5 separate times.
Which would totally skew the map. It makes that one trial seem 5 times more powerful and influential than it actually is.
Exactly. You'd think there was a mountain of evidence, when really it's just the same hill being photographed from 5 different angles.
Wow. How do they fix that?
To prevent that inflation, the researchers mapped out exactly which primary trials were inside which meta-analyses. If they found massive overlap, they selected only the most recent and highest quality meta-analysis to represent that unique combination, discarding the duplicates.
Okay, so to summarize this monumental effort, they took a chaotic, multilingual, math error-riddled database of human knowledge. They corrected the biological impossibilities. They translated everything into a single universal statistical currency. They made sure nobody was double counting their receipts. And then they unleashed an algorithm to slap a giant warning label on anything that was poorly designed or biased. That is a truly rigorous, virtually bulletproof filter.
It is as close to a definitive view of the evidence as modern science can currently produce.
Knowing that the satellite map is highly calibrated and knowing we can finally trust the coordinates, it is time to zoom in on the actual landscape.
Let's do it.
And I want to start where the anxiety is often the highest. I want to start with the most frequently asked question, the thing parents agonize over the most at the pediatrician's office. What actually works right now in the short term for kids and teens?
The data generated by the UREHA filter here is actually quite clear and robust. We are specifically looking at the short-term window here, which the researchers define as typically around 12 weeks after the start of study.
Okay, 12 weeks. What did they find?
For children and adolescents, the review found 5 specific pharmacological drugs that showed statistically significant improvements in core ADHD symptoms.
Meaning primarily inattention and hyperactivity.
Right, exactly. And this was with at least moderate certainty evidence.
Okay, let's list the 5 out clearly for the listener.
They fall into 2 main categories. First, we have the stimulants, amphetamines and methylphenidate. Second, we have the non-stimulants, atomoxetine, alpha-2 agonists, which is a class that includes medications like guanfacine and clonidine, and finally, viloxanine.
And all of these worked.
All 5 of these options demonstrated medium to large effect sizes in reducing the severity of core ADHD symptoms in the pediatric population.
Before we talk about the differences and how well they work, let's quickly explain the biological difference between these categories. I think a lot of people hear stimulant and non-stimulant, and they don't really know what's actually happening in the brain.
That's a very fair point.
If I am taking methylphenidate, a stimulant, versus atomoxetine, a non-stimulant, what is the actual mechanism at play? My baseline understanding is that ADHD involves a lack of certain neurotransmitters, right?
That is the foundational theory, yes.
Okay.
The primary neurotransmitters implicated in ADHD are dopamine, which is heavily involved in reward, motivation, and motor control, and norepinephrine, which regulates alertness, arousal, and executive function.
Okay, dopamine and norepinephrine.
In a neurotypical brain, these chemicals are released into the synaptic cleft. That's the space between neurons.
Yeah.
They do their job, carrying a message, and then they are reabsorbed by the brain, a process called reuptake.
Got it.
In a brain with ADHD, the theory is that these neurotransmitters are either underproduced or they're reabsorbed way too quickly.
Leaving the brain constantly searching for stimulation just to reach a functional baseline.
Exactly.
So how do the stimulants fix that?
Stimulants, like methylphenidate and amphetamines, are essentially the blunt force instruments of this process, and I mean that in a highly effective way.
Blunt force. Okay.
They primarily work by blocking the reuptake of both dopamine and norepinephrine. By blocking that reabsorption, they force those chemicals to pool and hang around longer in the synaptic cleft.
Making sure the message gets delivered.
Right. Amphetamines go a step further and actually stimulate the release of more dopamine. It's the equivalent of turning up the master volume dial on the brain's alertness and focus centers.
Okay, turning up the master volume. I like that visual. And the non-stimulants.
Non-stimulants take a more targeted, nuanced approach. Atomoxetine, for example, is a selective norepinephrine reuptake inhibitor. It primarily focuses just on blocking the reabsorption of norepinephrine with much less direct impact on dopamine.
And the alpha-2 agonist, you mentioned guanfacine.
They work completely differently. They actually mimic norepinephrine by binding directly to specific receptors in the prefrontal cortex,
Mm-hmm.
which is the area of the brain responsible for higher-order executive functioning.
So if stimulants are turning up the master volume?
Non-stimulants are more like fine-tuning a very specific frequency on the radio dial to clear up the static. They take longer to build up in the system, but they don't have the same dramatic peaks and crashes that stimulants can cause.
That makes a lot of sense. So we have these 5 distinct chemical tools that clear the high bar of moderate to high certainty evidence. But when you look at the actual source material from the BMJ, there is a very clear standout in the pediatric data.
There really is.
Methylphenidate. It seems to just dominate the efficacy charts here.
It dominates completely. When the researchers isolated the data for methylphenidate in children and adolescents, it showed consistent, significant benefits across all the different types of people rating the symptoms.
This is crucial.
Very. Whether it was the highly trained clinician observing the child in a medical setting, the parent reporting on the child's behavior from home, or the teacher reporting from the classroom, methylphenidate consistently showed a standardized mean difference greater than 0.75.
Which, as we established in our math breakdown earlier, is right on the border of a large effect size.
Exactly. And importantly, because of the rigorous UR-each filter, the certainty of this evidence was verified as moderate or high. We aren't guessing here.
Right.
But perhaps the most crucial data point for methylphenidate isn't just its raw power to reduce symptoms, but its acceptability profile.
Okay, we need to clarify some terminology here because the study draws a very strict, distinct line between 2 words that the average person uses completely interchangeably: acceptability and tolerability.
Yes.
What is the difference in this context?
This distinction is vital for understanding the real-world application of these treatments. In the context of this umbrella review, tolerability is a very narrow, specific metric.
Narrow how?
It refers exclusively to participants dropping out of a clinical trial because of adverse side effects.
Oh, okay.
It is a pure measure of whether the human body can physically or psychologically handle the presence of the drug. Did it cause severe insomnia? Did it cause nausea? Did it increase heart rate to an uncomfortable degree?
So tolerability is just side effects. And acceptability.
Acceptability is a much broader, all-encompassing metric. It refers to participants dropping out of the trial for any reason whatsoever.
Wait, why else would someone drop out if not for side effects?
Countless reasons. Maybe the drug simply didn't work at all and the parents got frustrated and pulled their kid from the study. Maybe the dosing schedule was too complicated to maintain.
Oh, like taking it 3 times a day versus once?
Exactly. Maybe the family moved to a different city halfway through the trial. Maybe the kid just hated swallowing pills.
So acceptability is essentially the ultimate real-world test of a treatment. It answers the question, will the patient actually continue to take this long-term?
Precisely. It balances efficacy, side effects, and convenience into one metric. And for methylphenidate in children and adolescents, its acceptability was significantly better than a placebo.
Really? Better than a sugar pill?
Yes. It achieved a risk ratio of 1.58, supported by high certainty evidence.
Break that 1.58 number down. What does that mean for the kid taking the pill?
It means that children were significantly more likely to stay enrolled in the trial and continue taking the medication if they were given methylphenidate compared to if they were randomly assigned to the placebo sugar pill.
Because presumably the methylphenidate was working well enough and providing enough tangible relief in their daily lives to make any minor inconveniences or mild side effects totally worth enduring.
Exactly. The benefit heavily outweighed the cost.
And speaking of side effects, the study did look closely at the major concerns, specifically decreased sleep and decreased appetite, which are notoriously common with stimulants.
They did. And while it is true that these pharmacological interventions generally showed lower tolerability than placebo overall, the nuance matters.
What's the nuance for the kids?
For methylphenidate and for the non-stimulant atomoxetine in the pediatric population, the difference in dropouts specifically caused by adverse side effects was not statistically significant when compared to the placebo group.
So the kids' bodies were generally handling the medication well enough to stay the course.
Yes.
But here's where it gets really interesting, and it highlights a massive quirk in how we measure human behavior.
I know exactly where you're going with this.
You mentioned earlier that methylphenidate showed consistent benefits no matter who was doing the rating, the doctor, the parent, or the teacher. But when you look at the data for the other major stimulant, amphetamines, the map gets a little weird.
It does. It highlights a massive psychological and environmental variable that researchers have to constantly battle.
So looking at the BMJ source material, it notes that for amphetamines in children, The clinicians, the medical doctors, rated the symptom improvements with a massive effect size, a standardized mean difference of 1.02.
Which is huge.
That is a huge, undeniable improvement, backed by moderate certainty evidence. But when you look at the ratings from the parents and the teachers for that exact same drug, in those exact same trials, they only reported small to medium effects, hovering under 0.60.
Right.
And worse, the algorithm downgraded the certainty of the parent and teacher evidence to low or very low. Why the huge discrepancy? Why would the doctor see a massive night and day improvement, but the parents and teachers barely notice a change?
It is a fascinating phenomenon, and it comes down entirely to the environment and the nature of what is actually being observed. Think about how a clinician evaluates a child.
In an office.
Right, they do it in a highly controlled, optimized setting. The clinician's office is quiet. It is structured. There are no distractions. The interaction is usually relatively brief, maybe 30 to 60 minutes, and it is focused on very specific, structured tasks or conversations.
Okay, so it's a bubble.
In that sterile environment, the ability of amphetamines to enhance acute short-term focus and suppress overt physical hyperactivity is incredibly obvious to a trained eye. The doctor asks the child to sit still and complete a puzzle, and the child does it perfectly.
Right. The environment is practically engineered to showcase the drug's primary mechanism of action.
Exactly. But now consider the parents and the teachers. They are not observing the child in a sterile office. They are observing the child in the chaotic, unstructured, constantly shifting reality of daily life.
A classroom is the opposite of sterile.
Think about a teacher in a classroom with 30 other kids. They are asking the child with ADHD to transition seamlessly from reading to math, to navigate complex social dynamics on the playground during recess, to deal with sensory overload in the cafeteria.
That's a lot of cognitive load.
Or think about the parent at home. They aren't measuring if the child can complete a puzzle in a quiet room. They are measuring if the child can find their shoes, remember their backpack, eat a waffle, and get out the door by 7 a.m. without having an emotional meltdown because their socks feel weird.
Oh man, the morning routine chaos. It is the ultimate stress test for executive function.
It really is. The demands on emotional regulation, shifting attention, and complex task management in those real-world environments are infinitely more complex than sitting in a doctor's chair.
So, while the core symptoms of inattention might technically be improved on a clipboard in the clinic, the practical, lived experience of the parent or teacher dealing with the holistic child might not reflect a massive, life-altering change.
Right. The drug helps them focus, but it doesn't automatically teach them the organizational skills they lack. And it might not prevent the emotional dysregulation that happens when a video game is turned off.
That makes total sense. A pill can turn up the volume on focus, but it doesn't magically pack the lunchbox.
Exactly.
And it illustrates beautifully why this umbrella review was so meticulously designed to explicitly separate the data by rater type. They purposefully isolated the clinician data, the parent data, and the teacher data.
If they had just lumped all those symptom scores into one giant average number, it would have been incredibly misleading.
It would have masked that vital discrepancy between clinical efficacy and real-world utility.
It is a true testament to the rigorous methodology of the URVC framework. They preserved the nuance.
Okay, so to synthesize the short-term landscape for the kids, methylphenidate is the strong, well-tolerated all-rounder. Amphetamines show incredibly strong clinical focus, but have mixed real-world reviews from parents and teachers.
Yes.
And non-stimulants like atomoxetine and alpha-2 agonists are solid, viable options, especially if you need a different mechanism of action.
That's an excellent summary.
But as you mentioned at the very beginning of this deep dive, up to 70% of cases continue into adulthood. The burden doesn't stop at age 18.
It absolutely does not.
So if you are a listener who was diagnosed later in life as an adult, or perhaps you're a teenager currently aging out of pediatric care, does this same playbook apply to you? Can an adult just look at the pediatric data and assume the same rules apply?
They absolutely cannot. When we shift the focus of the umbrella review to the adult data, the landscape changes dramatically, and frankly, the options narrow. The list of highly effective treatments shrinks significantly.
Oh. So what is actually left on the table for adults? What clears the bar?
In terms of showing at least medium efficacy for core ADHD symptoms, supported by moderate to high certainty evidence, we're left with a very short list. We have only 2 drugs and 1 non-pharmacological intervention.
2 drugs, that's it.
That's it. The drugs are the non-stimulant atomoxetine and the stimulant methylphenidate.
Wait a minute, what happened to amphetamines? You just said they were a massive heavy hitter for clinical focus in kids. Why aren't they on the primary adult list?
Amphetamines present an interesting case in the adult data. They only joined the effective and certain list when the researchers performed a very specific sensitivity analysis.
What kind of sensitivity analysis?
They decided to run the algorithm again, but this time they restricted the data exclusively to high-quality trials that had a definitively low risk of bias. When they stripped away all the mediocre studies, amphetamines did show a medium effect size based on clinician ratings with high certainty evidence.
Oh, I see.
But in the broader, primary analysis that included all eligible data, the signal was too noisy. They didn't make the primary cut.
That is fascinating. The rigorous filter actually saved amphetamines, but only when you zoom in on the best of the best data. Now, you also mentioned one non-drug intervention made the cut for adults.
Yes. The third intervention that demonstrated moderate certainty evidence for medium efficacy in adults was cognitive behavioral therapy, or CBT.
Okay, so the core adult toolkit is atomoxetine, methylphenidate, and cognitive behavioral therapy. But we really need to talk about the physical cost of taking those medications for adults, because the BMJ paper highlights a very stark, very concerning contrast between the pediatric side effect profile and the adult side effect profile.
This is where the concept of tolerability becomes a major, sometimes insurmountable hurdle in adult ADHD treatment.
Remind us of the definition again.
Remember, tolerability is the rate of participants dropping out of a trial, specifically because the adverse side effects become unbearable. In children, as we discussed, methylphenidate and atomoxetine didn't show significantly worse tolerability than placebos.
Right, the kids generally handled it fine.
But in adults, the story flips completely. The very drugs that had moderate to high certainty of actually reducing symptoms also had high certainty evidence of possessing significantly worse tolerability than placebos.
Let's look at the actual risk ratios the researchers calculated to understand the magnitude of this problem.
Okay, so for methylphenidate in adults, the tolerability risk ratio was 0.50. For atomoxetine, it was 0.45. For amphetamines, it was 0.40.
Okay, those numbers sound small, but in statistical terms, they are massive. What does a risk ratio of 0.50 or 0.40 mean in plain English for a 35-year-old listener trying to get through their workday without having a panic attack about a spreadsheet?
A risk ratio of 0.50 means that adults taking these medications are roughly twice as likely to drop out of a treatment program because the side effects become intolerable compared to adults taking a placebo.
Twice as likely.
Yeah, and a ratio of 0.40 means they are even more likely to quit.
Twice as likely to just throw up their hands, flush the pills, and say, I can't do this anymore. The cure is literally worse than the disease.
Exactly. The physiological response in adult bodies to these specific compounds seems to be much harsher. Or, it could be the compounding effects of adult lifestyles.
What do you mean by adult lifestyles?
Adults are often already dealing with baseline stress, sleep deprivation from work or parenting, heavy caffeine intake, maybe hypertension.
Oh, right. We're already running on empty.
Exactly. When you introduce a powerful stimulant or a norepinephrine reuptake inhibitor into that already stressed system, it leads to a much higher rate of treatment abandonment due to issues like severe insomnia, total loss of appetite, heart palpitations, or increased anxiety.
So, if you are an adult listener seeking treatment, what does this all mean for you? It sounds like you are bracing for a massive trade-off.
It is a significant trade-off.
You might get the focus you desperately need to keep your job, but you are going to pay a heavy physical tax to get it. Which leads me to a really important question about the goals of treatment. Are we just looking at core symptoms here?
What do you mean?
Like, great, the methylphenidate lets me stare at my computer screen for 4 hours straight. But my heart is racing, I haven't eaten since yesterday, and I'm snapping at my spouse. Do these treatments actually improve a person's holistic daily life?
That is the vital next step in the clinical analysis, and the BMJ researchers were very thorough here. They looked beyond just the core symptoms of inattention and hyperactivity. They analyzed what are called secondary outcomes.
And this is where it gets tailored, right?
Yes, this is where the specific nuanced strengths of the different drugs start to emerge, allowing for a much more personalized approach.
What kind of secondary outcomes are we talking about? If the core symptom is focus, what else is there?
They looked at a wide range of functional metrics, things like emotional dysregulation, the inability to manage intense feelings, leading to outbursts or deep crashes.
A huge issue for a lot of people.
Very huge. They looked at broader executive functions, the complex cognitive processes like working memory, long-term planning, and physical organization. They looked at academic performance and general self-reported quality of life.
And what did the adult data show for those secondary outcomes?
It revealed distinct profiles. For adults, the non-stimulant atomoxetine showed high certainty evidence for creating small improvements, specifically in emotional dysregulation.
Interesting.
Methylphenidate, on the other hand, showed moderate certainty evidence for small improvements in broader executive functions.
And how does that compare to the secondary outcomes we see in the pediatric data?
In children and adolescents, atomoxetine showed small to medium improvements in overall generalized quality of life with moderate certainty. Amphetamines, despite the mixed parent and teacher reviews on core symptoms, showed medium improvements specifically in academic performance, again supported by moderate certainty evidence.
So there is a really important layer of nuance there that dictates treatment choice. An adult might look at their life and realize their primary struggle isn't necessarily staring at a spreadsheet. Their primary struggle is emotional volatility.
Exactly.
They're getting overwhelmed and snapping at their colleagues or their kids. That person might lean heavily toward atomoxetine.
Precisely.
Whereas an adult whose emotional regulation is fine, but they are constantly losing their keys, missing deadlines, and failing to organize their day, might lean toward methylphenidate to target those executive functions. It is absolutely not a one-size-fits-all fix the ADHD pill.
You have to match the tool to the specific deficit. And this is why the creation of the EB-ADHD database by these researchers is such a crucial advancement.
The living database.
Yes. A clinician and a patient can sit down together in the office, pull up the database, identify the specific secondary outcomes that are causing the most distress in the patient's life, and filter the data to find the intervention that targets that specific issue.
While simultaneously weighing the specific tolerability risks for their age group.
It turns it from a guessing game into a highly informed strategic decision.
However, given those massive dropout rates for adults due to side effects, that punishing 0.50 risk ratio for tolerability, I imagine any listener dealing with this condition is naturally going to wonder about non-pharmacological alternatives.
Absolutely. It's the first question many people ask.
If the pills are making me feel nauseous or ruining my sleep architecture or spiking my blood pressure, what else is out there?
It is a necessary and completely rational question. And the Umbrella Review looked extensively at non-drug strategies. They cast a very wide net here.
What did they look at?
They analyzed data on dietary interventions, including things like restricted diets or elimination diets. They looked at physical training and exercise protocols. They looked at neurofeedback, which involves monitoring brain waves and trying to consciously alter them.
Okay.
They looked at acupuncture and, of course, various psychological therapies.
And what did the satellite map reveal about the natural or non-drug route? Did anything shine through the filter?
It revealed a very frustrating, almost paradoxical truth for patients looking for alternatives.
Oh, no.
Many of these non-drug interventions, specifically acupuncture, physical training, and certain dietary interventions, actually showed what the researchers termed apparently large effect sizes.
Wait a second. Large effect sizes. So the math says they work really well.
The raw statistical output in the meta-analyses suggested they had large effect sizes. In some cases, the raw numbers looked as good or better than the medications.
So what's the paradox?
However, and this is a massive landscape altering, however, the certainty of the evidence supporting those large effect sizes was systematically universally rated by the grade algorithm as low or very low.
Hold on, I need to push back hard on this on behalf of the listener, because this sounds incredibly unfair.
It does sound unfair at first glance.
If a study shows that acupuncture has a huge positive effect on a child's ADHD symptoms, or that removing artificial dyes from their diet drastically reduces hyperactivity, but the certainty is rated low just because of some rigid study design rules programmed into an algorithm, does that mean we just throw the data in the trash? Should a patient completely ignore non-drug options just because the grade system gave the researchers a bad report card on their methodology?
If we connect this to the bigger picture of evidence-based medicine, the answer is absolutely not. We do not throw it in the trash.
Okay, good.
It is vital to understand that a low certainty rating does not mean the intervention is ineffective. It does not mean it is snake oil.
Then what does it mean?
It simply means the scientific community does not currently have the rigorously designed large-scale data required to confidently guarantee that it is effective. It means we need better trials, not that the treatment is useless.
Okay, so why exactly does the grade algorithm hate these non-drug trials so much? Why are they all getting systematically downgraded while the pharmaceutical trials pass with flying colors? Is the system biased toward pills?
It isn't a bias toward pills. It's a structural limitation of how we conduct the scientific method. It all comes down to inherent methodological biases that are incredibly difficult and sometimes physically impossible to eliminate when you aren't using a pharmacological agent.
Impossible to eliminate. Like what?
The gold standard of any clinical trial is a double-blind setup. That means the patient doesn't know if they are receiving the real treatment or a fake placebo.
Right.
And crucially, the doctor or researcher evaluating their symptoms doesn't know either.
You have to eliminate the placebo effect, where a patient feels better just because they think they're being treated. And you have to eliminate observer bias, where a researcher accidentally sees improvements that aren't there because they want their new treatment to succeed.
Exactly. Now, achieving a double-blind setup is relatively easy in pharmacology. You manufacture a sugar pill that looks, tastes, and weighs exactly the same as a methylphenidate capsule. Nobody knows who has what until the trial is over and they break the code.
Makes sense.
But how do you blind a participant to physical training? You can't.
Yeah.
The participant is acutely aware that they are sweating on a treadmill or doing complex coordination exercises.
Wait, yeah, you can't placebo a treadmill.
Exactly. And you definitely can't give someone placebo acupuncture session. I mean, they're going to know if their needle's sticking into their skin or not.
Right. The same goes for cognitive behavioral therapy. You cannot blind a patient to the fact that they are sitting in a room actively talking to a trained therapist about coping strategies.
Because of this fundamental lack of blinding, both for the participants experiencing the intervention and often for the investigators who are assessing the outcomes, these trials are inherently at a much higher risk of bias. The placebo effect is allowed to run wild.
So the algorithm catches that.
Furthermore, these non-drug trials usually suffer from very small sample sizes.
Why are they so small?
Economics and logistics. It is relatively cheap and easy to hand out a bottle of pills to 500 people and tell them to come back in a month. It is staggeringly expensive, time-consuming, and logistically complex to hire acupuncturists or personal trainers or dietitians to individually treat 500 people for 3 months.
Oh, it's absolutely.
So these non-drug trials often only have 20 or 30 participants.
So the algorithm looks at the data and says, okay, you are claiming a massive effect size, but you didn't blind the study, the patients knew they were getting treated, the evaluators knew who was getting treated, and you only tested this on 28 people. I do not trust your math.
That is precisely the mechanism. The algorithm flags a high risk of bias for the randomization process and the outcome measurement, and it drops the certainty rating to low.
But let's theorize for a second. Even if the certainty is low, why do researchers think these non-drug interventions might work? Like, what is the biological mechanism that connects running on a treadmill or changing your diet to improving a neurodevelopmental disorder like ADHD?
While the clinical trials lack certainty, the theoretical mechanisms are heavily researched. Take physical training, for example. We know that vigorous aerobic exercise stimulates the release of endorphins, but more importantly, it acutely increases the availability of dopamine and norepinephrine in the brain.
Wait, the exact same neurotransmitters that stimulants target?
Yes, exercise acts like a natural temporary stimulant. It also increases blood flow to the prefrontal cortex, aiding executive function.
Okay, that makes sense. And what about diet? How does food impact focus?
Dietary interventions, particularly elimination diets, are based on the theory of the gut-brain axis and systemic inflammation. The hypothesis is that certain individuals with ADHD may have undiagnosed food sensitivities.
But to what?
Perhaps to artificial dyes, preservatives, or specific proteins like gluten or casein. When they consume these trigger foods, it causes a mild immune response and systemic inflammation.
And that affects the brain.
That inflammation crosses the blood-brain barrier and disrupts neurotransmitter function, manifesting as hyperactivity or brain fog. By eliminating the trigger, you calm the immune response and stabilize the brain.
So the biological theories are incredibly sound, even if the clinical trials are too small and unblinded to prove it definitively. Now, you did mention earlier that there was one notable exception in the non-drug category. Cognitive behavioral therapy for adults actually made the final cut alongside the medications.
Yes, it did.
How did CBT beat the algorithm?
It was a significant achievement. For adults, CBT actually achieved moderate certainty evidence for medium efficacy, specifically when rated by clinicians. It was the singular non-pharmacological intervention that managed to break through the certainty trap for core symptoms.
Why CBT and not the others?
This is likely because the protocols for adult CDT and ADHD are highly structured, deeply studied, and the trial designs have become much more sophisticated at minimizing observer bias, even if patient blinding is impossible.
So bringing this all back to the listener who is exhausted by medication side effects and wants to try an alternative route, what do they practically do with this low certainty information about diet or exercise or acupuncture?
The researchers emphasize a very pragmatic approach. This data should absolutely not eliminate non-drug options from your life. Instead, it should inform the risk-reward calculation you make during shared decision-making with your doctor.
Okay, risk-reward.
Think about the harm profile. If rigorous physical training has a potentially large effect size but low certainty evidence, what is the downside of trying it?
Well, you might pull a muscle, but that's about it.
Right. The harm profile of exercise is virtually non-existent, and it has 100 other cardiovascular benefits. The risk is incredibly low compared to starting a powerful stimulant. You just have to manage your expectations regarding the scientific guarantee of its success.
It might work beautifully, or it might just make you physically fitter without helping your focus.
Exactly. The same goes for an elimination diet. The risk is low, even if the guarantee isn't there.
All right, so we have established a really solid understanding of the short-term landscape. We know what works at the 12-week mark. We understand the tolerability trade-offs between kids and adults. We know the blinding issues that hold back the data on non-drug therapies.
We covered a lot.
But here's the elephant in the room. ADHD is not a 12-week cold. It is not a broken arm that heals. You take the cast off and you never think about it again. It is, for the vast majority of the population, a lifelong, chronic neurodevelopmental condition. So what happens at 26 weeks? What happens at a year? What happens after a decade of taking methylphenidate? What does the high-definition satellite map say about the long term?
Prepare yourself, because what I'm about to tell you is arguably the most shocking, paradigm-shifting finding of the entire 4,632 record umbrella review.
Okay, I'm ready.
When the researchers looked at medium and long-term follow-up, which they defined as 26 weeks and 52 weeks respectively, there was absolutely no high or moderate certainty evidence found for any intervention.
Wait, none? Are you telling me that out of 221 meta-analyses, nothing showed long-term proof?
None. Zero. Across all age groups, children, adolescents, and adults, across all pharmacological drugs and all non-pharmacological interventions, they found absolutely no moderate or high certainty evidence for sustained benefits on core ADHD symptoms or even on secondary outcomes.
I am genuinely expressing profound disbelief right now.
It is stunning, isn't it?
We are spending hundreds of billions of dollars globally on a lifelong condition. Millions of people, including young children, are taking these powerful psychotropic medications every single day for years, sometimes for decades of their lives. And you are telling me that the absolute pinnacle of medical science does not have gold standard, moderate to high certainty proof of what happens after 6 months.
That is exactly what the data reveals. It is a staggering void in the scientific literature. The only tiny glimmer of hope in the entire long-term analysis was mindfulness meditation in adults, which showed some potential for long-term improvements in executive functioning.
But even that was low certainty, right?
Very low certainty, according to the algorithm.
This raises a massive, terrifying red flag for anyone currently in treatment. How is this possible? How can modern medical science, with all of its funding and technology, have such a colossal blind spot regarding one of the most common neurodevelopmental disorders on the planet?
It is deeply unsettling. But this raises an important question about the very nature of how we conduct medical research and the inherent limitations of relying exclusively on the randomized controlled trial as our singular gold standard for truth.
Explain that to me. Why aren't researchers just running long-term trials? Just keep the study going for 5 years.
There are several massive barriers. First and foremost is cost. Running a rigorously controlled, multi-center, double-blind clinical trial is staggeringly expensive.
Just paying all the people involved.
You have to pay teams of researchers, clinicians, data analysts, and facility costs. Keeping a trial running at that level of strict oversight for 52 weeks, let alone 5 years, is financially prohibitive for almost any research institution or pharmaceutical company. The funding simply isn't there.
Okay, money is always an issue. What else?
Second, you have the issue of dropout rates. As we discussed at length, the tolerability of these medications, particularly in the adult population, is a major hurdle. Keeping a statistically significant, mathematically sound number of people enrolled in a strict trial for an entire year when a huge percentage of them are experiencing adverse side effects is practically impossible.
The data pool shrinks until it is useless.
Exactly.
Okay, so you run out of money and you run out of patience. But I imagine there is a massive ethical issue here too, especially regarding the control groups.
The ethical barrier is arguably the largest one. Think about the design of a gold standard trial. You need a placebo control group to compare against the treatment group.
Right. Someone has to take the sugar pill.
If you are a researcher, is it ethically justifiable to withhold a known, highly effective short-term treatment from a struggling child or a failing adult for an entire year, just to satisfy the rigorous requirements of a scientific study?
Oh.
If a child is failing out of school, suffering severe social isolation, and developing depression secondary to their ADHD, keeping them on a sugar pill for 52 weeks while their life falls apart is extremely hard to justify to an institutional ethics review board.
You can't ask a human being to sacrifice a year of their life just to be a clean data point.
Exactly. Once a drug is proven effective in the short term, it becomes ethically highly questionable to deny it to the control group long term.
So we are trapped in a scientific catch-22. We rightfully demand perfect, pristine, long-term randomized controlled trials to give us the high certainty evidence we crave to feel safe. But the reality of human biology, research economics, and basic medical ethics makes those exact trials practically impossible to execute.
Precisely. The rigid structure of the system has created a gaping void in our long-term understanding, at least based strictly on clinical trial data.
So what is the solution? If the BMJ researchers mapped the entire landscape and found a giant, terrifying black hole right in the middle of it, what do they suggest we do? We can't just stop treating people after 12 weeks.
This brings us back to the ultimate forward-thinking mission of the paper and the author's innovative solution: the EAD ADHD web platform.
The living database.
Yes, EAD-ADHD-database.org. The researchers recognize that publishing a static paper in a medical journal in 2025 cannot possibly fix a long-term data void. The paper is outdated the moment it goes to print. So they built this umbrella review architecture to function as a living database.
Meaning it updates itself automatically?
It won't be automatic, but it will be actively and rigorously updated annually by the research team. As new network meta-analyses are published around the world, and as new, better-designed trials are completed, that fresh data will be fed directly into the UReach algorithm.
So the map will redraw itself year after year?
But more importantly, the researchers explicitly note in their conclusions that in the future, if we ever hope to fill this specific long-term void, we have to fundamentally shift our perspective.
Shift it how?
We have to look beyond just randomized controlled trials. We have to start aggressively incorporating high-quality observational studies into the evidence hierarchy.
Okay, we have covered an immense amount of ground today. We have gone from the microscopic mathematical errors buried in old meta-analyses all the way up to the macro level, systemic gaps in lifelong psychiatric treatment data. Let's do a final synthesis for the listener. What are the core, undeniable takeaways from this massive evidence filter? What do we know for sure?
First, we know that in the short term, specific pharmacological interventions, both stimulants and non-stimulants, are highly effective at managing core ADHD symptoms.
Especially for kids, right?
For the pediatric population, children and adolescents, methylphenidate clearly stands out for its potent combination of high efficacy and strong acceptability, meaning kids actually stay on the treatment.
But the moment you transition into adulthood, the entire playbook changes.
Correct. The options for adults backed by moderate to high certainty evidence narrow significantly to atomoxetine, methylphenidate, and cognitive behavioral therapy. And crucially, adults must navigate a much steeper, harsher tolerability trade-off.
The side effects are just much harder for adult bodies to handle.
Yes. The very drugs that work effectively also carry a significantly higher risk of causing adverse side effects that drive patients to abandon treatment.
Then there is the dilemma surrounding non-drug interventions. We have therapies like acupuncture, elimination diets, and physical training that show apparently large effect sizes in the math, but they are trapped in a low certainty rating purely because it is physically impossible to double-blind a treadmill or an acupuncture needle.
Which means they shouldn't be ignored or discarded, but they have to be weighed differently in a risk-reward conversation.
And finally, we have the shocking, undeniable void in long-term data. Beyond the 26-week mark, modern medical science currently lacks any high or moderate certainty evidence from clinical trials to definitively prove sustained benefits for any intervention.
Largely due to the ethical and financial constraints of running long-term placebo trials, as we discussed.
Which is exactly why the researchers didn't just publish a paper, they built a tool. The EB-ADHD platform is open access. It is sitting on the internet right now, waiting to facilitate shared decision-making.
It exists so that you and your doctor aren't guessing in the dark.
Or relying on a single, flawed, biased study you stumbled across on social media. You can pull up the database, filter the overwhelming amount of data by your specific age group, look at the specific secondary outcomes that are actually ruining your day-like emotional regulation or poor working memory, and make a treatment choice based on the best, most mathematically harmonized data available on Earth right now.
It truly democratizes the absolute highest level of scientific evidence. It puts the power back in the hands of the patient and the clinician.
But I want to end on a thought that builds directly on what we just discussed regarding that terrifying long-term void in the data. You mentioned that the researchers know we need to look at observational studies to fill the gap where clinical trials fail. And looking closely at the source material, the authors point to some recent observational data that is, frankly, absolutely mind-blowing.
They do highlight this as the path forward. They point to studies that utilize massive, linked national prescription databases.
So not a trial.
We are not talking about carefully controlled trials with 50 hand-picked people in a sterile clinic. We are talking about messy, real-world data tracking hundreds of thousands, sometimes millions, of individuals over the course of many years.
And what does that incredibly messy real-world data actually show about the long-term impact of taking ADHD medication?
It shows profound, life-altering benefits. The observational data indicates that the sustained use of ADHD medication drastically reduces the risk of death from unnatural causes.
Wow.
It significantly lowers the risk of suicidal behaviors. It lowers the risk of severe substance misuse, unintentional physical injuries, and catastrophic road traffic accidents. It even shows slight long-term improvements in broad academic achievement and measurable reductions in long-term criminality.
That is staggering. The perfect, sterile, highly funded clinical trials cannot tell us what happens after a single year. But the messy, chaotic reality of millions of people just living their lives, filling their prescriptions at the local pharmacy, driving their cars on the highway, and going to work every day. That massive wave of data tells a clear story of profound, life-saving impact.
It is the ultimate real-world proof.
So I will leave you with this to ponder as we wrap up. At the start of this deep dive, we talked about how deeply we desire the clean, binary, black and white certainty of an X-ray. We want the perfect clinical trial to hand us the perfect, undeniable answer on a silver platter. But maybe in a world where perfect long-term clinical trials are ethically impossible and financially unfeasible to run, maybe the messy, uncontrolled, beautifully complex data of millions of human beings just trying to navigate the chaos of their daily lives is actually the key. Maybe that massive imperfect reality is how we finally understand the true lifelong impact of treating ADHD.